Okay. So the next case study is completely different, and it's pretty cool because you kind of see me evolving now. Or Francesca said I'm a Pokemon already. So this is a case involving trauma, very severe trauma, multiple things going on with this guy. So the story with him is he was being a good Samaritan, helping his neighbor out, and trying, I guess, I don't know if they were trying to put the utility pole in the ground, is that the story? And it ended up falling and crushing his chest, and he, I believe, fell in the hole, and he coded. So when paramedics arrived on the scene, he had no pulse, and they were able to revive him, but he is kind of a mess. So he suffered an anoxic brain injury, and there are 4 types of anoxic brain injuries. An anemic anoxia results when the blood is unable to supply the brain with enough oxygen. That can result from either chronic anemia or even carbon monoxide poisoning can cause that. Toxic anoxia is just as the name suggests. That can also be from carbon monoxide poisoning or any other toxin. Anoxic anoxia is kind of what you think of from classic suffocation, where there's just not enough air supply, or enough air or oxygen in the air. Usually that happens when people go mountain climbing and there's not enough oxygen available, and they don't even realize that they're gonna suffocate, unfortunately. In his particular case, he suffered from stagnant anoxia, and that is essentially caused by an internal condition that decreases the oxygen supply to the brain, and that's often caused from either cardiac arrhythmia or cardiac arrest in his case. Can also be caused from stroke. So some potential cognitive effects of anoxic brain injury include short-term memory loss, decreased performance in what's known as executive functions, which are basic judgment, reasoning, ability to process thoughts. Anomia, which is the ability to, what I'm having trouble with right now, put things into context, or when you kind of confuse one word for the other, that's what anomia is. It's a type of aphasia. Visual dysfunction, so inability to see certain shapes or colors, anything like that, or more severe, of course, visual dysfunctions. So Glasgow Coma scale, I know you guys are all familiar with, but basically just a way for type of assessment for them to categorize patients in their motor response, eye-opening, verbal. He, in particular, is only responsive to pain. He has no verbal response and has abnormal extensions. So right now he scores at a 4, and he's considered comatose. I haven't seen him today, so I can't say that. This is all as of Friday of last week. So for blunt chest trauma, there's primary concerns. You have airway disruption. They usually immediately intubate to protect the airway. Hypovolemia, so right away they're pumping fluids into them and making sure that you protect from hypotension. They treat aggressively, usually with crystalloids. Rib fractures and pulmonary contusion. Pneumothorax, he actually had a bilateral pneumothorax, both lungs collapsed. Hemothorax is a big concern. It can result from a ruptured spleen, and up to 40% of the blood volume can be accommodated in the hemothorax. Aortic injury is another huge concern. 80 to 90% of aortic ruptures, if they occur prior to them arriving at the hospital, the patient usually doesn't make it. Myocardial contusion and diaphragmatic ruptures. These are all things that can occur with blunt chest trauma. One thing I didn't put on here is, of course, liver damage. Some Aspen guidelines, M&T for critically ill patients. These are very, very general guidelines. Number 1, we need to determine if the patient has pre-existing malnutrition. Typo. And then, of course, prevent further progression of malnutrition. And if the gut is functional, we want to, of course, use enteral nutrition over parenteral nutrition whenever possible, and monitor ins and outs for fluid and electrolyte balance. In our particular trauma neuron SICU, we're going to encourage nutrition support therapy aggressively, so we want within 24 hours. And our trauma protocol is volume-based feeding as opposed to the typical rate-based feeding. So our goal is 60% of the total daily volume goal, and we will monitor gastric residual volumes daily. So we try to educate our nurses to go for less than 400 mLs before they raise red flags, but sometimes they get nervous once it hits 200. We're monitoring labs daily and eyes and nose daily, and we are constantly collaborating with the healthcare team for plan of care. So this is Mr. SM. Because he was unconscious and intubated, sedated, we have a limited medical history that we were able to obtain from his son. He's a 57-year-old Hispanic male, and from his son we know that he has no diabetes, no hypertension, no history of heart disease, only that his father had heart disease. No history of smoking, and I'm actually going to go into his list of problems here. So he's status post-crush injury by utility pole with an anoxic brain injury and a skull fracture. He did start seizing. He had myoclonus. He was constantly twitching in his bed. And post-traumatic respiratory failure with the pneumothoraces. They did end up putting chest tubes in him when he was in the OR. Bilateral rib fractures, bilateral pneumonia, status post-cardiac arrest, advanced cardiac life support when they resuscitated him, and anemia of critical illness, and left clavicular fracture. These were his vitals. He was tachycardic and hypertensive. So day 1, biochemical data, white blood cell elevated, of course, with the trauma inflammation, and acute stress response indicated by his glucose and albumin, and ALT and AST elevated, most likely because of the blood trauma, and most likely creatinine's a little low because of that as well. His nutrition assessment, slightly overweight, and that's probably going to work in his favor as we're going to expect him to lose weight. He's going to be here long term. So his estimated needs, we compared our 30 to 35 kilocalories to Penn State and gave him a high protein, 1.5 to 2 grams per kilograms. Nutrition diagnosis was based on intake, inadequate oral intake related to patient intubated, as evidenced by enteral nutrition needed for sole source of nutrition. So, as I said, we go aggressively, and we wanted him to have his enteral nutrition support via OG tube within 24 hours. We recommended Pivot 1.5 because it's an immune-enhancing nutrition formula that we often use in the trauma setting, and we implemented our trauma protocol of volume-based feeding, which we usually start at 24 mL and increase by 30 every 4 hours. And then the recommendation of IV fluids at 125 normal saline. So this is an example of the volume-based feeding schedule that we try to train the RNs on. So if, just as an example, this patient had 1,800 as his daily goal, and he had only received 400 mLs and had to go off the floor for a procedure, and he had 13 hours left. I have to go to the next page. Then the way that the RN would have to figure 1,400 over 13 hours is she would go right over here, and 108 would be his new goal rate for the day, in order to get 100% of his needs met. So, research on immune-enhancing nutrition and traumatic brain injury. In this retrospective review, 240 TBI patients between 2009 and 2013 were fed either an immune-enhancing nutrition or standard formula. Those patients that received the immune-enhancing nutrition had lower rates of bloodstream infections, even though they had a longer stay in the ICU and had more ventilation. So on top of that, their prealbumin levels were higher in weeks 2 to 4. So despite the fact that they were in the ICU longer, they had less rates of infection. And they had similar lengths of stay, similar mortality, similar pneumonia, but overall, the researchers did conclude that those who received the immune-enhancing nutrition, such as Pivot, which is what we feed, did have a benefit in improved nutrition status and decreased rates of bacteremia. So our goals for nutrition therapy for trauma patients, usually to administer nutrition within 24 hours, that the patients tolerate their tube feeds, and to definitely advance to a PO diet as soon as it's medically feasible. So when we're monitoring these patients, we're monitoring their weight, tube feed rate, tolerance, inputs and outputs, biochemical data, and plan of care. Complications that occurred with this patient are gastroparesis. As of the 7th, tube feeds had to be held. He only received 45%, which is outside of our desired 60%. But we worked with the doctor and increased bowel regimen, took a look at what he was receiving, added Reglan. His residuals were within normal limits, so eventually we were able to resume the goal rate. Then he started vomiting. So things weren't looking very good for him. We did notice that his OG2 was pretty high up in the stomach, so our RD made the recommendation, post-pyloric Dophoff tube, and we did recommend another pro-motility agent. That recommendation was not taken. We just went ahead with the Dophoff tube and started doing trophic feeds, so he was getting at least some nutrition, and we didn't completely cut him off. We put trauma protocol on hold. The doctors were starting to all convene, started talking to the family about palliative care. Things just overall were not looking good for him with the vomiting and everything else that was going on with him at the time medically. Only the trauma doctor was the one who said it's not time to talk palliative. They were all consulting, and we were just doing our thing with the trophic care, our trophic feed, and waiting to see what happened. I'm not happy with this because it's a transpyloric feeding as opposed to post-pyloric feeding. However, it did still give pretty good feedback in terms of saying that enteral nutrition via transpyloric versus regular gastric route had lower incidence of pneumonia and just in general gave higher amounts of diet versus the gastric, and they had lesser incidence of gastric residuals. So I couldn't find the research I wanted on post-pyloric. But it did have 104 adult patients with traumatic brain injury, and it's going in the direction I wanted to say that sometimes with the traumatic brain injury, post-pyloric or transpyloric in this case may be a better route, even if just temporarily. So he did progress. As of Friday, he was doing so much better. And the family did say, no palliative, we're going to push for aggressive care. And he was tolerating 2 feet with 0 gastric residuals as of Friday. He didn't have any more emesis for 48 hours. All sedation was discontinued. The only complication he had left was high urine output, and the doctor was monitoring that to see if he was going to keep his sodium was trending high towards hypernatremia. He wasn't quite there, he was at 140, but there was a little bit of edema starting to occur. So plans right now are in place for a trach and peg. So this is the trend for him. Obviously they were taking a lot more labs, but for when the main incidents occurred, these are the trends of his labs. His glucose was doing really great throughout all this, so I was happy with that. But you could see the sodium trending a little high, and the doctor was thinking his sodium might trend towards 150 pretty soon. These are his current medications, just for medical accuracy. I'm not going to really delve into all that. And prognosis. He's got a lot of people on board, and it's going to take a long time for this to play out. And so next steps are trach and peg, like I said, and he'll need to be monitored, have a cog eval once he's able to, and determine what the actual physical and cognitive impacts were of this injury, these injuries I should say, and determine his nutrition status. We'll be working eventually, hopefully, with the SLP and doctor for recommendations to advance him to his PO diet once we get there, and the usual monitor for dysphagia, see what he's able to tolerate, and soon we'll be educating the family on PEG tubes and water flushes to maintain hydration, and hopefully he'll be doing well. So I will be seeing him today, actually. Any questions? Tristan?
I wasn't sure if you looked into this, but it has to do with like cachexia that happens to patients who are trauma patients, and the whole inflammatory process that drives that. And I think one of the things with Pivot is that anti-inflammatory, it's an anti-inflammatory formula. So I wasn't sure if you had looked into it or not, but
not for this particular case, no.
Okay.
But I can.
It's okay.
Okay. Yeah, this one I didn't do.
Nutrition, the IEN, the enhancing nutrition that you're speaking about.
Yeah.
Is there a point in time when that's no longer working? Like it's enhanced as much as it can, and you can go back to another formula that might not be as expensive?
That's a good one. I'll go back to it.
Because a lot of CVI patients, I mean, they're going to be on enteral feeding the rest of their lives. I used to work in a CVI clinic, so I'm just wondering at what point is that no longer feasible or an option, or is there a time when it continues to be enhancing?
Let me see if they hinted anything.
I kind of asked that when we had that Abbott presentation that we had about the guidelines, and I don't think she really gave a good answer either.
No, she didn't. She
just
chatted
said
around the question.
whenever you want.
I remember. That's
And
why
I
I'm
was
asking
like,
her.
Okay.
Yeah.
What
She
was-
didn't answer it.
What was that?
You weren't here.
It was at the scan meeting.
Yeah.
She didn't give me anything.
So, and a good guideline is, so for Aspen, they recommend 5 to 10 days. That's when you decrease their calories a little bit. I really don't adjust it even then. So at least 10 days you want to keep it on. And then after that, I look at, are they going to more surgeries that are going to, perpetuate the inflammation?
I will say this,
Or
the
no?
prealbumin was,
Like after that, so 2 weeks at least.
I was just curious.
the prealbumin was higher weeks 2 through 4, but then not in week 5.
Okay.
So that may be somewhat of an indicator.
That runs
But I'd
pretty
have
well
to look
if you
into
just
that.
2 weeks is a good marker
Yeah.
for starting to monitor it like daily or every couple of days. Yeah. And then I have a question for the volume-based feeding. When you were saying to figure out the remainder, you switched over to the 1,300 mils. Is that because that's what was left over?
Say that again.
So you said their total was 1,800 mils, and then when you went to calculate it, you went over to the 1,300 bar.
For what was
Yes.
left over.
So
Yeah.
you were saying because you gave them 400, you
Yeah.
were going based off 1,800 and then nothing.
Correct.
Okay.
Did I do that right?
I
Okay.
just wanted to make sure. I missed the 400, so I was like, did you say that you got them right?
Yeah.
Okay.
Yeah, okay.
Okay, good.
Anything else?
How's he doing today? Did you check on him?
On SM?
Yeah.
No, because I did rounds and then I only checked on the 16-year-old. I peeked in on her real quick, but I have to go back and check on him. He's not my official follow-up, but I just want to call him and see how he's doing.
I have trauma rounds in 45 minutes.
Oh, thanks.
Yeah, he definitely made a turn. I was nervous that first week.
Oh,
I don't know what he's gonna.
yeah. Okay. And that's it.
Good
That's
job.
all I got.
Good job.
Thanks.